Hello. Good morning, viewers at home and around the world. We are happy to be back today on Health Matter on WAP TV. Today we'll be continuing with the topic we started a week ago. What is this topic? Closing the gaps in asthma care. Closing the gaps in asthma care. With me today in the studio is a family health physician, Dr. Femi Omotosho. Femi, you're welcome to the studio.
Yeah, good morning.
Thank you very much for coming to join us today.
Yeah,
okay, having been with us last week.
Yeah.
Yes. Now, what do we need to know about the closing gaps that have to do with asthma care? What are the gaps that need to be closed? Number one, we want to understand what asthma is all about. Asthma is a chronic lung infection, an infection that has to do with the lungs, oftentimes characterized by inflammation that ends up blocking or narrowing the airway. And as a result, such individuals will come down with symptoms like breathing difficulties, wheezing, cough, and shortness of breath. And to close the gaps in asthma care, we need to look at areas where we have inequalities between one nation and the other. We need to close the gaps in care and management as well as diagnosis. I'll be yielding the floor to the expert we have in the building to tell us what we need to know. Once again, you have the floor, and you're welcome to the show.
Yeah, thank you very much, Dr. Barth. Good morning once again, our viewers.
Yes.
So, as you've rightly said, in continuation of our discourse from last week, we're still looking at asthma care, closing the gaps in asthma care, still in commemoration of the World Asthma Day, which was celebrated this week on Tuesday. So basically, for our viewers, the public, as we talked about last week, there are some perspectives, there are some areas that directly affect us as people who are not directly in the healthcare space in terms of what do we need to know about asthma care. So the basic thing is, the first thing is the issue of the communication and education for the general public, for us to know what asthma rightly is. We talked about this briefly last week. We need to properly communicate what asthma is, because asthma as a chronic condition, which you've rightly said, is a condition in which people who have it live with it for the rest of their life. And so we need much more than the care they receive in the hospital, the care and support from the home and the community. And that's why people in this setting, as the general public, needs to understand what the disease is. It's a chronic condition. It's not an acute, even though we have acute attack. And so it's going to be taken care of lifelong. But the good news is that we have medications that can adequately control it in such a way that individuals with asthma can live their normal life. So basically, one of the aims of this World Asthma Day, which we are commemorating also today, is to help us know that asthma is not a death sentence. Asthma should not be stigmatized. That's people with asthma should not be stigmatized. And people with asthma can live their normal life once they adhere to the medications their doctors prescribe for them, and also the importance of continuous medical checkup. One of the things that we notice, especially in this environment, is that we don't have that good health-seeking consciousness or behavior in our environment, which we need to improve on, especially for diseases that are termed chronic, in which asthma is one of it. Unlike a condition like maybe an infection, maybe malaria or any other form of infection, in which an individual has, you see your healthcare practitioner and within 1 week you are discharged, and that's all. However, for conditions like asthma, even when you've seen your medical practitioner and he or she has placed you on medication, that is not all. I'm sure they will give you an appointment. Depending on how well controlled you are, you need to continue to see your physician. Because that's one of the things we find. Some people would be well controlled over a period of maybe 2-3 years, and then they stop seeing their physician, stop going for their routine check, and then before you know it, they come down again at the emergency with an attack. So that's one of the things we need to pass across during this week, during this period, that asthma is a chronic condition, and as long as an individual is asthmatic, the person needs to continue to see his or her doctor on a regular basis. It doesn't have to be every month. For people who are well controlled, the appointments could just be once in 6 months or once in a year, just for your doctor to see you and re-examine your medications and be sure that you're on the right path. So that is it. That is very important. That's one thing we must take away from this our discourse today and from this World Asthma day celebration for this year. That continuous interaction with our HCPs is very important. And then for us in the community, from the home and in general public, we need to support patients who have this condition in terms of encouraging them also in their way of lifestyle. Last week we talked about the issue of avoidance of trigger factors. So we talked about, we won't dwell much on that. Asthma patients need to know the trigger factors which they are used to, and then they know how to avoid it. They also discuss this with their caregivers, and also discuss it with people in their close environment, in the homes, in the environment, so that they can support them in being able to avoid these trigger factors and being able to live their normal life. So, and we said again last week, I want to reemphasize this, that the mainstay in terms of asthma management, which is one of the core gaps we're trying to close in this year's communication, is that we should know that inhaler medication, science has shown now, is the mainstay for asthma management. Because we found out, especially in this environment, that people are not really welcoming to that. They are averse to using of inhalers. At times, it's even stigmatized. This should not be so, because science has shown that inhaler medications is the right way to go in taking care of asthma and in achieving good control, which can make patients with asthma live a good quality of life. So that needs to change. That person needs to change that. Some people will tell you that, once you move from tablet medication for asthma to inhaler medication, it's as if your asthma is getting worse. No. It just shows that you are using the current science that we have that shows that asthma is best managed using inhaler medication. And then if you are on that inhaler medication, then obviously you'll be well controlled. And when I'm talking about inhaler medication, especially when we interact with our doctors, we're talking now about inhaler medication that contains inhaled corticosteroids plus a long-acting beta agonist.
Thank you very much. Thank you very much for that elaborate description. But for the benefit of those who did not join us last week, when we come back after the break, we'll do a recap of some of the things we have talked about last week, the signs and symptoms of asthma, as well as the types. Please go nowhere. We'll be right back. And in the studio with me today is Dr. Femi Omotosho, and the topic we are discussing is closing the gaps in asthma care. Don't forget, last Tuesday was World Asthma Day. As a matter of fact, every second Tuesday in the month of May is actually mapped aside as World Asthma Day. It's a time that will create awareness about this scourge, what you need to know and what you need to do to stay safe. I'd like to open the phone lines at this stage so that viewers at home can put in their calls, make their contributions, should there be any. Okay, so before we went on that break, I was saying that we're going to start with a recap of some of the signs and symptoms of asthma, because it is not all the disease entities that can actually present with difficulty in breathing are asthma. A good number of them are not asthma. Okay, so but we need to hear today the signs and symptoms of asthma, as well as the types of asthma. And of course, what causes asthma or the risk factors. We just want to do a recap because we did justice to it last week. Over to you, Dr. Femi.
Yeah, thank you, Dr. Barth. And okay, just as a form of quick recap, as we said last week, there are 4 cardinal symptoms of asthma, even though that's not exhaustive, but those are the 4 cardinal. Number 1, cough, then chest tightness, wheeze, then difficulty in breathing. The presentation of asthma, it could be one of these symptoms, 2, or a combination of all these symptoms. But we know the 4 cardinal symptoms, as I've said: the cough, chest tightness, wheeze, and difficulty in breathing. So any of these symptoms could be the presenting situation of asthma. So, and as you rightly said, not all cough is asthma. So moving further, for today, we talk a bit about what we call in medicine differentials. What could other conditions that could mimic asthma? I'll start. For asthma, we know asthma could occur across any age. So usually in children, when you're thinking of differentials of asthma, the first thing you want to think about is, could this also be a case of bronchial pneumonia? That's the commonly called pneumonia. So pneumonia too could present with cough. It could present with difficulty in breathing. So, but usually one factor that usually distinguishes pneumonia out, as in you can clinically know that this is not asthma, is pneumonia usually presents with fever, which you will not see in asthma. So in asthma conditions, it's not an infective condition. It's more of an allergic, even though we have some conditions in which now we have some few non-allergic asthma, but majorly asthma is allergic. It's an allergic condition. So when you're talking of pneumonia in a child, maybe a child having cough, difficulty in breathing, and you're not sure is this pneumonia or asthma. Once there's a presence of fever, that's a temperature greater than 38.5 degrees centigrade, then obviously you know that is not likely going to be asthma until proven otherwise, because asthma doesn't present with fever.
Thank
so that's
you very much.
A common thing in
thank you very much.
Talk
children. To us about asthma and, of course, COPD overlap. I do know that nothing stops somebody who has asthma probably from having any other disease condition like chronic bronchitis or even emphysema in some cases. So what do we need to know about asthma and COPD overlap?
Yeah, thank you very much. Thank you very much, Dr. Barth. That's also another very interesting issue in asthma. Asthma COPD overlap. Yeah, as I said, there are differentials of asthma. Commonly across the age group, when you talk about asthma generally, COPD is also a very common differential of asthma. So, but because they have similarities and also they have differences.
And what's the full name for COPD?
So, yes, for our viewers, COPD basically means chronic obstructive pulmonary disease. Chronic obstructive pulmonary disease. So, it's actually a spectrum for some common conditions affecting the respiratory system. One of it is chronic bronchitis. Then another one is emphysema. So, when you have this spectrum, we call it, in general, chronic obstructive pulmonary disease. So people with COPD, in short, could have chronic bronchitis, they could have emphysema, they could have it together, or could have it individually.
So what differentiates them out? The difficulty in breathing, is there a pattern of difficulty in breathing in asthma and, of course, in COPD?
So, yes, as you rightly said, why we usually say asthma COPD overlap is because they are very similar. So, as I said earlier, the 4 cardinal symptoms that we have in asthma, that's the cough, chest tightness, wheezing, and then difficulty in breathing.
Yes.
These 4 symptoms are also present similarly in COPD. So that's one area in which, to the general public, you wonder, so what will be the difference? The same symptoms you have in asthma, you can have them in COPD. But from the presentation and from the etiology, we've talked about asthma. We said asthma is heterogeneous, meaning there is no one specific cause for asthma. There are different trigger factors. There are different factors that we look at as a possible etiology, as a possible cause of asthma. But we can't pin asthma to just one particular condition, to one particular state, to one particular cause. However, for COPD, it's known generally that the commonest cause of COPD is smoking. And COPD usually occurs. I say usually occurs, that means in most cases occurs usually after the age of 40 years. So when we talk about asthma, asthma can occur across all ages. But you would very unlikely see COPD in a child. You know, I use my words carefully. I said usually, you know, in medicine, we have this terminology that will say never in medicine. Anything can occur. But usually COPD, so mainly for most cases of COPD, it occurs after the age of 40 years. And there's a known cause. Majorly it's caused by smoking. So that is one distinguishing factor in terms of when you are taking your history, or even generally when you talk in the community, yes, could this be asthma, could this be COPD? So if you have all these 4 cardinal symptoms in a 10-year-old, so obviously you know this is not likely to be COPD, because COPD usually doesn't occur in that age.
Another major difference is that oftentimes the difficulty in breathing one may have if such an individual has COPD, it stays there even when you have commenced treatment. It doesn't go away. So sometimes the symptoms can be recurrent. But that of asthma, the difficulty in breathing could go away for several months, oftentimes to years, for some people who have mild asthma. So these are some of the differences, just like as pointed out. Now, we are in COVID-19 era. What link does asthma have with COVID-19? But before you take that question, we'll have Jeffrey from... Jeffrey, good morning.
Yeah, good morning, sir.
How are you today?
I'm fine, sir.
Yeah, nice to have you.
Please, sorry, I want to ask a question, please.
Please go ahead.
Please, this cardiopulmonary failure, is it in, let me say, asthma?
Okay, thank you very much. Doctor will answer the question. He wants to know cardiopulmonary failure. Sometimes when someone dies, they say they died of cardiopulmonary failure. He wants to know, does it have to do with asthma? Any other question?
No.
Okay,
No.
thank you very much. So listen, doctor will take it.
Okay, thank you, Jeffrey, for that interesting question. Cardiopulmonary failure. Usually, when I'm on here, when we're talking to the public, we don't usually like to use all these big, we call them medical jargons or medical words. So cardiopulmonary failure is one of those big words. It's especially for the general public. So when you say cardiopulmonary failure, it's a big word. You have to bring it down. We are talking of a failure in two systems of the body.
Yes.
We have a lot of systems in the body, but when you talk about cardiopulmonary failure, we're talking of failure in the cardiac system and also the pulmonary system. So, and usually it doesn't just occur. It's usually more of an entail of a progressive condition that has been there for, if not months, years, usually. So cardiopulmonary failure is usually an end stage of a chronic condition that's already affecting the heart and the respiratory system. What it just means generally for us to understand is that the heart is about stopping to function, and so also for the respiratory system. And usually at this stage, if this is not reversed or if this is not altered, obviously the end result is death. This is not obviously in any way related to asthma.
Because we mentioned COPD.
Yeah. And COPD is also different from cardiopulmonary failure. So as Dr. Barth rightly said, in terms of COPD and asthma, and that way, which he said, I just want to simplify again, in which we can know if this is likely to be COPD or asthma, is that for patients with COPD, COPD is a progressive condition. So even when they use their medication, they get some relief, meaning somebody is having difficulty in breathing, somebody is having cough, uses his medication for COPD or uses the medication and gets some relief, but it doesn't get back to the best level of breathing that the person actually desires. Whereas for asthma, asthma is completely reversible. So when an individual has asthma attack and takes the appropriate medication, the person gets back to the ideal and normal level of breathing. So the person knows he's fully back. But for COPD, because it's a chronic condition, and I said it's commonly caused by smoking, yes, the individual takes medication and gets better. However, it doesn't get back to the optimal 100% level, but it gets better and the person can still live well. So that's another common way in which you can distinguish between COPD and asthma. But for cardiopulmonary failure,
and when we say chronic, we mean long-lasting.
Yeah.
Okay, acute means short-lasting. When we mention chronic, we are trying to say it's long-lasting. Good morning, sir. How are you today?
I'm fine. Good morning.
Yeah, thank you very much. Nice to have you.
All right.
So do you have any contribution to make or question?
All right. I wanted to make an inquiry.
Yeah, go ahead.
I'm also an asthmatic patient, so
okay.
So I normally take Franol. Sometimes I take the Ventolin inhaler. So my question particularly is on the Franol tablet. I used to take some few cases. I've been taking these drugs since I'm a child. So I wanted to make an inquiry if there is any side effects of taking these particular drugs.
Thank you very much. You will hear from the expert, sir.
All right.
Yeah, thank you very much. Our friend from Taraba.
Yes.
Yeah, I love this question because it's one of the gaps that we're actually addressing in World Asthma Day for this year. You said you're an asthmatic for years and you've been on Franol, Ventolin, and you want to know if there are side effects. In medicine, what we say is for every medication, even as simple as we say maybe a paracetamol, there's usually the side effects. So, but usually we weigh the benefits of the medication looking at it to the side effects. So if the benefits outweigh the side effect, then we'll tell you to take it. So for every medication, there are side effects. The same for Franol or Ventolin or whatever. But what I want to pass across is that as an asthma patient, if you are taking your Ventolin or Franol for 2 or more times, if you need to take it for 2 or more times in a week, then obviously your asthma is not well controlled. And as I said earlier, taking tablets for asthma medication on a long-term basis is no longer the way to go. So you need to, obviously, as soon as possible, latest Monday, this coming Monday, go to see your doctor and inform him that, yes, you listen to Health Matta and we talked about the need for you to be on inhaler medication.
Let me stop you a little. Yeah. Good morning, sir.
Morning.
How are you today?
Fine.
Thank you very much. We could barely hear you, sir. Can you do us a favor? Quickly turn down the volume of your TV set so that we can hear you. I think it could be the network. Please do call us back if you can. Yes, you were saying that the oral tablets and the injections and what have you are no longer the first-line management now.
So just to wrap up, our friend from Taraba, please see your doctor as soon as possible and tell him that you want to be placed on the right approach to asthma management, which is inhaler medication. So they will assess you first and determine the type of inhaler medication you need to be on. As you said in the clip, there are different types of inhaler medication. There are the reliever and then the preventer. For long term, it's better to be on preventer, which is usually the ones that contains 2 drugs, corticosteroids and then the long-acting beta agonists. So being on Franol is not the best way to be managed. It has its own side effects. Franol is a group of theophylline. It has side effects, especially if you take it maybe twice or more in a week. It has side effects on the heart. It has side effects on your...
I was wondering.
System.
Yes, he said he obviously is an adult and he has been taking this drug for childhood. Obviously, there hasn't been a review of his medication. Probably because he works for him, he decided to stick with it for decades now, not just years. Okay, so there needs to be an evaluation and a review. Thank you very much for calling in. Now, how is the diagnosis of asthma made? How do we diagnose asthma?
Yeah, thank you very much. Very apt and important question. For all we've said for our viewers in terms of helping us to, yes, be able to be familiar with the common symptoms of asthma, we should know that diagnosis of asthma is meant to be made in the hospital.
Yeah. Good morning, sir.
Morning.
How are you today?
I'm fine.
Yeah. Okay, so please go ahead with your contribution.
What I'm asking is, this asthma that they are discussing, is it hereditary or it is congenital?
Thank you very much, sir. Thank you very much,
sir. You.
Yeah. Yeah. Is it hereditary or is it contagious? I believe that should be the second part of the B part of his question. So, doctor will take the question, sir.
Yeah, thank you very much, Mr. Danke from Plateau. Yes, we said before that asthma is a heterogeneous disease, meaning that there are several factors that could contribute to it. So, in some conditions, it could run in families, meaning that it could be hereditary, but it is not contagious. Mr. A, who has a family history of asthma and who has asthma and is staying with Mr. B, who does not have a family history of asthma and does not have asthma, Mr. A will not transfer his asthma to Mr. B. No, it is not contagious at all. It's not an infectious disease, but it could be hereditary. It could run in families. And there are some people that even if it's not running in their family, it could be due to occupational exposure or environmental exposure.
Can be acquired later in life.
But it is not contagious.
Thank you very much. So the question was on diagnosis. How is the diagnosis of asthma made?
Yes. As I was saying, diagnosis of asthma, based on all the education we've given our viewers, knowing the symptoms, but we should raise that question that is not enough for us to stay in our houses or in our various places and just make a pronouncement of asthma on an individual. Diagnosis of asthma should be made by a medical practitioner, that's a doctor in a health facility. So meaning that when we see all these symptoms, the awareness you are raising is that when you see all the symptoms, you know that could this be asthma? And then you seek health care. So one of the cardinal focus of our discourse is for us to improve our health-seeking behavior. So when we see all the symptoms that we are talking about, then we need to seek health care. Go and see your doctor. And then in the facility, they again take this history, get this history from the patient or the healthcare provider, and then there are some basic tests that can be done or that will be done for us to make a diagnosis of asthma. We've said asthma is a chronic condition, meaning it's lifelong. So we don't usually label an individual asthmatic until some basic tests are done, and then there's a confirmation that this person actually has asthma.
Let me pause you a little. We'll come back to the basic tests that should be done to diagnose asthma after the short break. Please go nowhere. Thank you. Welcome you all back to the show. And with me today in the studio is Dr. Femi Omotosho. Dr. Femi, once again, we appreciate you. Yeah, first of all, I have to start with giving credit to American Lung Association and, of course, Asthma and Allergy Foundation of America for the video clips we used a while ago. We have seen some of the triggers that can actually make one to begin to have symptoms of asthma. It differs from one individual to the other. And, of course, some of them can be found in our environment. Our phone lines are still very much open. Before we went on that short break, I asked a question, which was asthma and COVID-19. What do we need to know? Because when COVID-19 started and we discovered that it has to do with difficulty in breathing, people started adding one or two together. People who are asthmatic, it's not going to be a palatable experience for them, alongside people who have other pre-existing medical conditions. But here we are today. We need to know.
Thank you very much, Dr. Barth. Yes, also another very important point, asthma and COVID-19. Yes, as we all know, yes, the COVID-19 disease is here with us and has been said in several quarters, is here with us to stay. But thankfully, the era of it being a public health emergency is gradually going away, and it's more of becoming an endemic with us, something that is with us, and we'll see how to manage it. So basically, COVID-19 on its own, because it's also an airway disease, actually can potentiate asthma symptoms, meaning it can worsen asthma symptoms. So COVID-19 obviously is different from asthma. COVID-19 is a viral infection. Asthma, we've said, is not a bacterial, it's not a viral infection. It's more of an allergic issue in most cases. So, but the thing about it is that for individual who is asthmatic and also who now maybe is exposed to COVID-19 infection, obviously it would worsen that individual's asthma symptoms. And this now brings to fore the need for adequate control, which we've been talking about since last week, for patients with asthma. So for an individual who is well controlled, even if inadvertently the person has COVID-19, because of the well-controlled background, the asthma symptoms will not be that exaggerated. But for somebody who is not well controlled, for example, somebody who is on oral medications and just uses the medications occasionally, and the person has COVID-19, the asthma symptoms will obviously be exaggerated. So the advent of COVID-19 brings to fore the need for patients with asthma to be well controlled. And that's why it's one of the cardinal information and education plan for this World Asthma Day, that patients with asthma needs to regularly see their doctors so that their medications are reviewed. Those who are on the wrong medications, for example, the oral medications, the Franol tablets of this world, the Ventolin tablets of this world, needs to be reviewed and placed on the appropriate inhaler medications. Because patients who are well controlled, even if they have COVID-19, the asthma symptoms will not be worsened because they are well controlled. However, those who are not well controlled, those who are on oral medication, if they have COVID-19, there is an increased likelihood that, apart from the COVID-19, the asthma symptoms would be worsened.
If I have asthma, can I go ahead and take COVID-19 vaccine? Is there any contraindication in people who have asthma?
No. Okay. That's a straightforward answer. There is no contraindication for taking COVID-19 vaccine because of asthma. That is not...
Yeah, before we went on that break, you were trying to answer questions on diagnosis, how asthma is diagnosed. And of course, we're talking about basic tests, lab tests and imaging investigation that needs to be done. Can you enumerate some of them to us, sir?
Yes, thank you very much. So for patients, as I said, once you have those symptoms, visit your doctor in the health facility, diagnosis will be made. They'll take a good history. Basically, they'll do a basic workup, blood workup, take some blood samples for some tests, but that, I said, would not in any way diagnose asthma. The two basic tests that we use to make a diagnosis of asthma are, one, we have what we call the peak flow meter. Peak flow meter is more of a surrogate for the actual gold standard for diagnosis of asthma. The gold standard is to do a spirometry test using a spirometer. But this particular machine is not commonly available across all our major facilities in the country. We have some facilities that have, especially the tertiary institutions, we have them, spirometry, and some private hospitals that are well developed. However, for facilities that don't have that, a peak flow meter can be used. But however, a peak flow meter cannot make a diagnosis of asthma on a single reading. That will need to be done at least 2 or 3 times in a week and for about 2 weeks. And then doctors know what to do. They will review the results and be able to make diagnosis of asthma. However, the gold standard is for a spirometry test to be done.
What about chest X-ray and CT scan of the chest? do they have a role in making the diagnosis?
So basically, in medicine generally, before we make diagnosis, we have different tests that we could do. We have what we call ancillary tests, and we have what we call the gold standard or definitive test. So when we talk of chest X-ray, CT scan, in diagnosis of asthma, they could be relevant, but they are basically what we call ancillary tests, meaning they could help you to look at what are the other possible issues this patient has. But when we talk of to make a diagnosis of asthma, chest X-ray cannot make a diagnosis of asthma, but chest X-ray can help you to look at other possible conditions in the X-ray. For example, if a patient comes to the hospital, yes, and you're thinking of asthma, there's nothing wrong with doing a chest X-ray. Number one, it serves as a baseline in which you can follow up. Then also, depending on the severity of the asthma, on chest X-ray, you could see some findings that could help you say, okay, this is likely going to be asthma. But it won't give you that final diagnosis. So that's why we say there are ancillary investigations. So it could help you support your diagnosis, chest X-ray, but it won't give you that final diagnosis. The only definite diagnosis can be made using a spirometer. That would tell you this is asthma. But chest X-ray would give you, say, okay, this may be asthma. Yes, you look at the result based on what you see. You say, okay, yes, it's showing some features that support asthma, but not giving you that definite diagnosis. So chest X-ray could support it, but to make that diagnosis, chest X-ray will not diagnose asthma.
Thank you very much. Now, I'll ask this question as a parent. Should children that have asthma be prevented from embarking on exercise? Because oftentimes when they do exercise, you discover that they will start having difficulty in breathing. What should be the way out? Should they be prevented from doing exercise while they are in school? Children with asthma.
Okay, thank you very much. Also a very important question which we get from our caregivers. So children with poorly controlled asthma or uncontrolled asthma obviously cannot benefit from being able to exercise freely. But however, children who are well controlled can involve in any activity they wish to do. And that's why we keep on emphasizing the need for control in asthma management. It's not just about patients waiting for the symptoms to come and then they use Franol, they use their tablets. No. Patients who are doing that obviously cannot be involved in exercise because you are waiting for the symptoms to come before using your medication. However, when we talk about control, meaning you see your physician, they place you on a regular medication. That medication regularly controls any form of symptom, prevent the symptoms from coming. So for such patients, for children who are on controller medications, that's inhaler medications that are preventers, they actually can be involved in exercise. But however, we said last week, for every patient with asthma, the care must be individualized. So even when they are well controlled and they can involve in exercise, the exercises may need to be graded depending on the individual child. But the key word there is that patients with asthma, once they are on appropriate medication, that's the controller medication, they can do anything they want to do in terms of exercise or any activity they can be involved in. Let me give you a typical example. I'm sure we're all familiar with the popular ex-footballer, David Beckham. Okay. For a long while, David Beckham was playing football, and most people didn't know he had asthma until the time when he left England and he went to Major League Soccer in the US, and during one of the games, while he was substituted, he picked up his inhaler and used it, and someone snapped it and put it on social media. And that was when people knew that, wow, this guy is asthmatic. But for years, he had been playing football. So asthma should not limit. So asthma should not limit our children. There are several world stars. There are several basketball stars that are asthmatic, but they reach the peak of their sporting career. But obviously, those particular people we're talking about were well controlled. They were not on tablets, they were not on Franol, because if you are on such medications, there's no way you can be able to live your life optimally. And that's why we're talking the issue of control. And control can only be achieved when you see your doctor and they place you on appropriate inhaler medication. These are the preventer medications.
Thank you very much. I'll ask this question. We had it last week a couple of times. Does asthma go away with time? Does asthma go away with time? In other words, can somebody who have asthma over a period of years
be cured of asthma?
No.
Okay.
Overgrow it. Okay. Helen from Plateau. Good morning. Helen, how are you today?
Hello. Fine, thank you. Good morning, sir.
Good morning. Nice to have you on the show.
What if a woman is pregnant? Will she take medication?
Thank you very much. Doctor will answer the question.
Yes.
Can a pregnant woman, thank you. Can a pregnant woman take asthma medications?
Yes, thank you very much. Ellen from Jos.
Yes, Plateau.
From Plateau, yes. So, basically, for patients who are pregnant, it depends on the category. So we could have two categories broadly: patients who are already on asthma medication before they conceive, before they get pregnant, or patients who are not on medication and they get pregnant and they find that they're asthmatic. So I'll look at it in those two categories. For patients who are already on their medication and are well controlled for their medication and they get pregnant, the advice is usually they must continue their medication. If the doctor needs to review it, the doctor will review. But once the patient is well controlled on the medication for asthma, then usually you want the patient to continue because that is what's keeping the patient controlled. If you now remove the medication because of pregnancy, most likely the patient would suffer attacks. So, but usually the doctor can review the medication based on the pregnancy and see, okay, do we need to step up the medication or step down? And when I'm talking of control, I'm not saying patients who have been using
or even change
tablets.
the medication entirely.
Yeah. So I'm not talking of patients who are using tablets. If a patient is using tablets and claims he or she is controlled, and the patient is pregnant, obviously you will need to see your doctor. You can't be pregnant and be on tablets or oral medication for asthma. It would not work. Obviously, that is already a pointer for attacks in that pregnancy. So when we take of a patient who is on medication, who is well controlled, we're talking of a patient who is on inhaler medication. Because if a patient is on tablet medication and feels he or she is controlled and conceives, there's an increased likelihood that the person will have an attack. But for those who conceive and then maybe they find out they have asthma symptoms and then they are now thinking, should they be on medication or not? For those, you need to see your doctor. For most of the time, yes, they will need to place you on medication too. Because the thing is, pregnancy conditions increases the risk of women to other stressful conditions. So pregnancy on its own could be a stressor in an individual. So because of that pregnant condition, you need to see your doctor, and most of the time they will need to place you on an inhaler medication. But they would assess you based on the level of your asthma. You know, we talked about categorization of asthma last week. Depending on how the asthma is categorized, either mild, moderate, severe, they will place you on the appropriate inhaler medication. But however, generally, it is not a contraindication in terms of being pregnant or being a contraindication to taking your medication. No. Usually, patients who are well controlled before being pregnant would continue their medication usually, except there's a need, which the doctor will review.
Thank you very much. Talking about types, what advice do you have? We do know that there's occupational asthma. In people who work in such environment that gets exposed to irritants that can actually predispose them to asthma, what should be your advice to such individuals? Should they go for a change of job or continue, or are there things they can do while remaining in that job?
Yes, thank you very much. It's very important. For people who have occupational asthma, the first thing is you have to report this to whoever is your manager or the head of the institution where you are working with. This is actually an emergency situation. You can't continue working in an environment that is at risk to your health. No matter the work we do, your health and safety usually is the first. I've not seen any workplace that your safety should not be the first. So your safety is the first priority. So usually, they are, depending on where you are working, they could, if it's a big organization or depending on the organization, they could do what we call a job substitution, in which you are put in another unit in which you won't be exposed to that particular irritant. That's usually where we start from. You want to substitute your job process. For example, if you work in a factory and then you work where dust is usually prevalent and you react to dust, then they could put you in the same organization, maybe in an office position where they don't have the dust from the factory site getting to. But however, if you work in a situation in which there is no way you can substitute and you work, no matter where you work in the organization, you are continually exposed to that irritant, then what we advise in that condition is you have to change that job, because if you continue doing a job that is affecting your health, then if you don't have a good health, you can't even come to that job in the first place. But usually the first step is you want to substitute, but if it's not possible, then you need to change job.
Wow, wow. Thank you very much. Thank you so much for coming around. You were with us last week, and of course, you came today to do a wrap-up of this show of asthma, how we can close the gaps in asthma care, in asthma management. So we are thankful to you, and of course to our numerous callers that called from home. We appreciate you. So we see you again next week for another wonderful show. Do please stay with us weekly.